Hello friends, welcome back to BGS Clinics. If you are watching general examination for the first time, then I suggest you watch the previous two videos first and then watch this one. Watching them in a sequence will be much better. In this video, we move on from vital parameters onwards. And at the end, I will discuss how to draw a conclusion of general examination. Temperature, pulse, respiration, and blood pressure constitute the vital parameters. They remain constant in normal healthy individuals. Vital parameters are so called because vital organs govern the values of these parameters. Even a slightest deviation from normal function of these organs is reflected in their values. Significant variations in these values may indicate life-threatening problems like insufficient consumption of oxygen, blood depletion with resultant hypovolemia, bacterial invasion, etc. Consequently, whether the patient's condition is improving or deteriorating can be judged by monitoring the vital parameters. The normal body temperature is 97 to 99 degrees Fahrenheit. And these are the abnormal body temperatures. These are on the lower side and these are on the higher side, which we call fever. Hypothermia and hyperthermia are medical emergencies. Patient should be hospitalized. What do you mean by pulse? Pulse is defined as an alternate expansion and recoil of an artery as the wave of blood is forced through it during contraction of the heart. Pulses are best palpable where arteries cross the bones close to the surface of skin. Can you recall quickly a few such areas and pulses? Okay, one in the head, one in the upper limb, one in the lower limb. Superficial temporal artery pulse is felt against the temporal bone. It is felt exactly underneath this ear stick of the spectacle. Okay, watch carefully. This is the place which is just in front and above the tragus of the ear. Alright. Do you know what this pulse is known as? It is known as anesthetist's pulse. That is because during any surgery below head and neck, this is the most convenient pulse to feel for monitoring. Otherwise, it becomes cumbersome crawling all the way down to search for the radial pulse covered under sterile drapes. The second one is, of course, the most commonly felt pulse in clinical practice, the radial artery felt against the anterior surface of distal end of radius at the wrist. The third is dorsalis pedis, felt on the dorsum of the foot against the navicular or cuneiform or proximal end of the first interosseous space at the base of the first metatarsal. In situations like a mass casualty, often with limited resources, palpating the radial or and dorsalis pedis pulses may help to triage the patients efficiently, skipping measuring blood pressure of all the patients initially. A normal volume radial or dorsalis pedis pulse suggests a systolic blood pressure above 80 millimeters of mercury. However, this judgment should be taken in conjunction with other assessment tools and not as the sole indicator of cardiovascular stability. A weak or impalpable dorsalis pedis pulse, however, does not necessarily suggest shock or even peripheral arterial insufficiency, as in about 14% of normal population, the artery may be of a small size. Do not use your thumb to palpate the patient's pulse, because sometimes thumb has its own pulse which may be misinterpreted as the patient's pulse. In infants, palpate the cardiac apical beat to count pulse rate. Which all parameters of pulse one should examine? Well, that way, pulse is a big topic. A general physician or a cardiologist will be able to talk on it for hours. But when we are doing basic assessment of pulse as a part of general examination, it is enough to examine the rate, rhythm, and volume. Rate means the number of beats felt per minute. The normal rate varies according to age. In the adult, it is between 70 and 80 per minute. Rhythm means regularity of the pulse. If rate or rhythm is found to be abnormal, then an electrocardiogram is indicated to identify the origin of the beats and the pattern of conduction. Volume means fullness of the artery. Two types of pulse are described with respect to volume: bounding and weak. Bounding pulse means full or large volume pulse with rapid rate, and that suggests increased stroke volume. Causes of bounding pulse are anxiety, anemia, hyperdynamic stage of septic shock, hepatic failure, heart block. Weak or 3D means a small volume pulse, and it is due to decreased stroke volume. Causes are hypovolemic shock and hypodynamic, that is later phase of septic shock. What is the normal respiration? 14 to 20 breaths per minute in a quiet regular pattern. An occasional sigh like this is considered normal. In adults, normal systolic blood pressure is between 100 and 130 millimeters of mercury, and normal diastolic is between 60 and 90 millimeters of mercury. In children, the mean systolic is 90 plus age in years, and the mean diastolic is 55 plus age in years. Jugular venous pressure reflects the right atrial pressure, giving an important clinical indication of blood volume status, cardiac functions, particularly the right heart dynamics. Assessing the JVP is a challenging though essential clinical skill. JVP is usually estimated on the right side since the right internal jugular vein has a more direct anatomical channel into the right atrium. Jugular veins and pulsations are difficult to see in children under 12 years of age. So, measurement of JVP in children younger than 12 years is not useful for clinical evaluation. You should learn the clinical skill of measuring jugular venous pressure. It is expected to be taught during your clinical rotations, both general medicine and general surgery. Normal JVP is 3 to 4 centimeters. JVP is low in dehydration and non-cardiogenic shock. JVP is high in cardiac tamponade, superior vena cava obstruction, tricuspid stenosis, hyperkinetic circulatory states, and pulmonary diseases. Body weight should be proportional to height. Changes in body weight result from changes in either body tissues, namely fat or muscle mass, or body fluid. Acute changes in weight occur due to changes in the amount of body fluid. Symptoms associated with weight loss often suggest the cause of weight loss. These are the common causes of weight loss. You may wonder how to memorize so many of them, but it is not difficult if you classify them into three practical situations. Causes of weight loss despite relatively high food intake, pathological causes due to decreased food intake, and psychosocial and physiological causes due to decreased food intake. Does it appear easy now? These are the causes of weight loss despite relatively high food intake: hyperthyroidism, diabetes mellitus, and malabsorption. Pathological causes, usually due to poor food intake, may be grouped into three sets: GI tract disorders, hepatobiliary and pancreatic disorders, and some general systemic diseases. GI tract disorders include major aphthous ulcers, chronic painful dental and periodontal disease, esophageal obstructive disease, gastric ulcer, worm infestation, fecal fistula, chronic vomiting, and diarrhea. It is not that difficult to remember the list if you carefully look at the sequence in which I placed them. Walk down from mouth to intestine. That's it. Hepatobiliary and pancreatic disorders include hepatitis, liver abscess, cirrhosis, and pancreatitis. And general systemic diseases responsible are tuberculosis, malignancy, AIDS, and any other chronic debilitating disease. And psychosocial and physiological causes include poverty, old age, social isolation, physical disability, emotional or mental impairment, lack of teeth, ill-fitting dentures, alcohol, and drug abuse. Patients' ability to function in daily life is a reflection of physiological status and reserves, and consequently can predict the ability to withstand a surgery. For objective assessment of performance status, grading systems are available. Karnofsky scale is one of the most commonly used at present time. Under the subjective methods, eyeballing the patient from head to toe may disclose the problems or uncertainties which may need further evaluation. Hand grip strength is assessed in the way I discussed in the previous, that is, the second video on general examination. In walk-climb test, take the patient for a brisk walk in a corridor and climb up one or two flights of stairs. The patient's ability to endure these physical challenges can predict the ability of cardiorespiratory system to withstand a major surgery. General examination should be carried out seriously because practically it means a lot. General examination must be concluded by determining the state of health, hydration, nutrition, and performance. Four states of health are described, into one of which your patient will fit: apparently healthy, sick, frail and feeble, and terminally ill. A patient who is conscious, with normal gait and posture, without any sign of distress is considered apparently healthy. A patient who appears sleepy, withdrawing from intellectual contact with the environment, or is unconscious, or has an abnormal posture, or is in distress is said to be sick. Patient with any advanced chronic illness or physiological aging may appear frail and feeble. A patient with sunken eyes and drooping eyelids is said to be terminally ill. How does this conclusion influence majorly in treating a patient? Any invasive treatment, including surgery, is simply out of question in frail and feeble and terminally ill patients. The second conclusion to draw is: what is the state of hydration? Is the patient dehydrated? Basically, why is it so important? Most of the cases requiring urgent surgical treatment are dehydrated due to various reasons, and many of them are also associated with loss of electrolytes and acid-base imbalance. For example, acute intestinal obstruction, acute perforative peritonitis, etc. One of the side effects of general anesthesia is a drop in blood pressure soon after induction. If patient is already dehydrated, a catastrophic drop in blood pressure will result in severe myocardial suppression leading in turn to acute cardiac failure. Hence, you should not take up a patient for urgent surgery without replacing fluids in a dehydrated patient. And needless to say, along with that, correct the electrolyte and acid-base imbalance as well. What are the clinical parameters which will give you an idea about the state of hydration? Now that you know how to conduct general examination, go back and pick up the relevant points applicable to this question. Look at the lips, tongue, skin, veins on the dorsum of the hands and feet with patient lying in supine position, pulse and jugular venous pressure. Okay? So, dry lips, tongue and skin, flat or guttered appearance of the veins on the dorsum of the hands and feet, weak volume pulse and low JBP suggest dehydration. The third conclusion to draw is, what is the state of nutrition? The patient may be either well nourished or else undernourished, cachectic, overweight, obese or super obese. All these come under the broad heading of malnutrition. Malnutrition is defined as a pathological state resulting from a relative or absolute deficiency or excess of one or more essential nutrients. These are the criteria of various types of malnourishment on the basis of body weight. The desired normal body weight ranges are available in height and weight tables. If the body weight is between 10 and 20% below the desired weight range, the patient is said to be undernourished. If the body weight is more than 20% below the desired weight range, the patient is said to be cachectic. On the higher side, if the body weight is between 10 and 20% above the desired weight range, the patient is said to be overweight. If the body weight is more than 20% above the desired weight range, the patient is said to be obese. And then there is an absolute figure of 180. Body weight above 180 kg qualifies as super obese. Apart from decreased body weight, what are the clinical signs of undernutrition? In other words, when will you label a person undernourished? When hair are depigmented and brittle. See, in parentheses, I have given the nutritional element that is deficient in different signs of undernutrition. Okay? All right. So when hair become depigmented and brittle, eyes show Biddot's spot, keratomalacia, mouth shows abnormal findings such as cheilosis, angular stomatitis, glossitis, pallor of the tongue, nails show koilonychia, skin becomes shiny, flaky, thin and dry, lower limbs show edema, muscles are wasted, and bones show deformities like bow legs, knock knees, etc. What are the clinical signs specifically of wasting? Hollowing of temples and cheeks, deepening of infraclavicular fossa, prominence of bony margins like metacarpals, spine of the scapula, obliteration of palmar hollow, and normal conical shape of lower limbs replaced by cylindrical shape. Please remember, however, symptoms and signs of malnutrition may be subtle and non-specific, such as weakness, easy fatigability, cold intolerance, flaky dermatitis, and ankle edema. Cachexia is an extreme degree of undernutrition where more than 20% of body weight is lost below the desired weight range. These are some of the causes of cachexia. In children, severe gastroenteritis, malabsorption syndromes, in adult thyrotoxicosis, diabetes mellitus, etc. In old age, severe cardiorespiratory disease, and causes common to all ages are prolonged severe starvation due to extreme poverty, drought, etc., advanced tuberculosis, advanced malignancy, and AIDS. Why is the state of nutrition so important in a surgical patient? Well, nutrition in a surgical patient is a big topic. I will make a separate video on it later. But to mention in brief for now, the incidence of surgical complications is high in malnourished patients. So, whenever possible, that means essentially before any elective operation, at least try to optimize the weight as far as possible. And then the final point in conclusion, the performance status. From this, you will get an idea if the patient is likely to withstand a major surgical operation or not, and accordingly, you will be able to derive the treatment plan that is safe for the patient. So that's all about general examination, a very, very important part of physical examination, irrespective of whether it's a medical case or a surgical case or an ophthalmology case or an orthopedic case or whatever. Thank you for watching.